Welcome to this episode of Knowing Your Way, Princess Margaret podcast for people affected by ovarian cancer. My name is Dr. Alicia Sarabia. I am a patient of the Comprehensive Ovarian Tumors Program at Princess Margaret Cancer Center. My guests today are Jodi-Ann Manhertz, a gynecologic oncology clinical nurse specialist at Princess Margaret, and Dr. Marcus Bernardini, head of the Division of Gynecologic Oncology at Princess Margaret and Associate Professor of Obstetrics and Gynecology at the University of Toronto. Welcome to the two of you and for making this podcast possible.
Hi, hello, hi everyone. Thanks for the introduction.
Today we'll be speaking about surgery as it relates to the experience of women living with ovarian cancer. As I think back on my own surgery, I very clearly remember the huge impact that the surgery had on my physical and mental well-being. It was a challenging time for me. And I remember thinking that if it wasn't for some medical knowledge that I had, it would have been even more difficult for me to get through this time. And so I think we all agree that more knowledge is better for patients and patients' families that are going through this phase of the treatment for ovarian cancer. And so with that, I thought it'd be a good idea to have Dr. Bernardini and Jodi-Ann Manhertz join us to help inform the listeners as they go along their journey. So Dr. Bernardini, why don't you start by telling us why it is that surgery is an important part of the patient's journey with ovarian cancer?
Yeah, thank you. Thank you again for the invitation to be part of this podcast series. I think surgery in ovarian cancer comes with so many layers of complexity and challenge in a way for patients. And I think this is a great podcast to try to help and manage them individually, which is a good strategy, I think, when you have too many things all together, to sort of let's take one at a time and get them. So ovarian cancer is unique, I would say, compared to other cancers. And I say that because when you think of cancer, we can think of it from the perspective of, it's in the origin, the organ of the origin of where it came from. And if you take it out with surgery, great. Maybe you need some more treatment, and you think of that for many cancers. And then you also can conceptualize sometimes the concept that, but the cancer has spread. And so when someone has a situation where the cancer has spread to other places, that maybe surgery is no longer the treatment of choice, because if the cancer is already spread, then we need to think of things like chemotherapy. And I say that ovarian cancer is a unique condition because on the one hand, we know that many people who have this diagnosis will present with disease, not just around the ovary, but elsewhere. So meeting, if you will, the definition of cancer that has already spread. But at the same time, we know that surgery plays a really important role in the management of this disease. And so in some ways, ovarian cancer is a mixture. It's not a pure cancer in terms of that way of looking at it, to say either it's just in the ovary or no surgery, or it's spread and it's just chemotherapy. It's a factor of, even if there's spread, there is a value of taking out tumor.
Okay.
And so just along those lines, that surgery becomes a critical piece in the management of ovarian cancer. And we know with very, very robust data for the fact that people who do not have surgery as part of their treatment, they do not live as long as people that do have surgery as part of their treatment.
Okay. All right. Right. And Dr. Bernardini, can you also tell us about surgery that is done very early after the diagnosis versus surgery that is done after a patient has received some chemotherapy?
Yeah, so as I said, this is where it gets to the complexity of things and even from a patient's perspective, hard sometimes to piece it all together. So we know that surgery is important. We know that not having surgery is definitely something that in many ways can impact negatively how long a person lives. So that part is clear. The goal of surgery, because that's an important question, insofar as we've said that the cancer may have spread, and in many cases it has, to other organs, how does surgery even work, and what is the goal of surgery? And there is a level of complexity when it comes to that. The simple answer is we want to remove as much of the cancer that we can see. In the ideal setting, we'd like to get to the point at the end of an operation where if we look with our eyeballs, which in some ways are rudimentary tools, that we don't see any cancer. Now, that doesn't mean there isn't cancer there, because with 100% certainty, there still are cancer cells, because cancer cells are at the microscopic level. But that outcome from surgery, again, is linked with improved outcome for the patient. So the more that you can remove, the better it is. Okay.
All right.
And so that decision making around whether to do it prior to any chemotherapy, meaning right after the diagnosis, versus after some chemotherapy, is based on this concept of in which way are we likely to remove more disease, by doing it up front or by doing it after some chemotherapy. And that's where that decision comes in. And so part of our program, every person that comes in right at that moment of diagnosis, they go through a comprehensive review, a meeting with multiple experts in the room, including the radiologists, including all the staff members. And we have scoring systems that have been established to objectify the planning, as opposed to just sort of saying, what do you think? Yeah, maybe we should, maybe we shouldn't. And that helps us to make that decision whether someone should have surgery right at the beginning or after some chemotherapy. And so that is all around this concept of trying to clear as much disease as possible. And so if we think before any chemotherapy that we can remove the maximal amount of disease that we can, then we decide to do surgery first.
All right. Thanks, Dr. Bernardini. Jodi-Ann, before we get into the nitty-gritty of the surgery itself, can you tell our listeners what kind of preparation is required by the patient before the operation takes place?
Sure. So after consultation and we decided on surgery as the option for treatment, we will do preoperative blood work. So that will include a complete blood count. So we want to make sure that your hemoglobin is looking good, that we don't have any issues with your electrolytes, your clotting factors are also okay. That way we'll have the opportunity to optimize it before surgery so everything goes well during and after as well. We'll also do scans, CT scans, abdomen, pelvis, and the chest. And the surgeons use that for staging and also to make the best decisions going into surgery as well. We will do ECG, EKG on certain patients, and the surgeons will make that decision as well as to which patients that will be necessary for. And we'll also look through the health history, and that will let us know if we need to do further blood work, whether a patient may have a fatty liver, we need to do more studies and things like that. In regards to prep for the surgery, you'll be seen into pre-admission and spoken to by the clinical nurse specialist, myself, in regards to how to prepare for surgery. We'll let you know when to stop eating, when to stop drinking. We'll go through all your medications, a detailed med history yet again. You'll speak with the anesthesiologist just to make sure you're well prepared to go into surgery, and we'll do it in the safest way possible. For some of our patients, we do a process that we call NPO at midnight, which is nothing by mouth that starts at midnight, where you have to stop eating at midnight. Then after midnight, you can have clear fluids up to 4 hours before the time of surgery. For other patients, and it depends on the extent of the surgery, we will do a bowel prep, and that involves clearing the bowels before surgery. The patient will receive a sheet and a prescription that goes to Mount Sinai, and then also instructions on how to prepare and do the bowel prep. So bowel prep starts about 2 nights before the day of surgery, and we'll start with medications to clear your bowels and a drink called Bipeg Light that will cause you to have multiple bowel movements, so we can have a clear bowel movement, have clear colon before the surgery itself. And then in regards to support during that process, because it is a lot of things and the patients can become overwhelmed with all of the requirements before surgery, try to give them a heads up as what is to be expected. During their pre-admission appointment, the patients will get advance notice as to when that appointment is and how long it is. It can be a little bit long, about 2 or so hours for that conversation, because it goes through a really detailed medical history and to prepare for surgery. And then I will call the patient as well and go through the surgical plan once more.
Great. Yeah, it's, as our listeners can appreciate now, it's a really, really busy time. There's a lot going on in terms of the preparation, let alone, the discussions you're having with your family, with friends, with work. It's a tough time. And so it's great that you're there to support the patient with at least the tests and other procedures that are required before the surgery itself. Dr. Bernardini, can you briefly comment on what staging is and why that's important for the patient?
Yeah, absolutely. So as I mentioned earlier, the majority of the time when someone presents with ovarian cancer, they're going to have disease not just around the ovary. And this is probably a good time to introduce this concept that although we call it ovarian cancer, we think the majority of the time it didn't actually start in the ovary. It started in the fallopian tube. Yeah. And this is why the majority of people, when they present with tumors, growths, basically, in their abdominal and pelvic cavity, which is really a big space. A nice way that I've heard it described by another surgeon is to think of pickles in a pickle jar, where the jar itself represents the abdominal pelvic cavity, the pickles represent the organs within the abdominal cavity, and the fluid around the pickles is really what that is, that peritoneal fluid in the abdominal and pelvic space. And so the fallopian tubes, if you can imagine, spill into the fluid space of where the pickles are, and they can then spread within that fluid and stick onto the different pickles. Mm-hmm. And really, that's really what the organs of the abdominal pelvic cavity are. So it's very common that someone with ovarian cancer will have disease and growths on their intestine, their large intestine, their small intestine, obviously the uterus itself, which is next to the ovaries and the fallopian tubes, the omentum, which is basically a big fat pad that is in the abdominal cavity, the liver, the spleen, the walls on either side. All of these areas can have tumor on them. And the CT scan, the imaging as you described it, is very important for us to give us an idea of where they are. And it's important, firstly, to tell us whether surgery before chemotherapy is the right decision, because sometimes there are certain things that we can remove and there are certain things that we cannot remove. For example, we cannot remove someone's entire small intestine. We can, but they'll never eat again. So that obviously is not a good strategy. So these are the kind of things that we look at to help us define, going back to the earlier point, should they have surgery right at the beginning or should they have surgery after some chemotherapy?
Okay.
And this, I would say, also adds to some of the complexity from the patient point of view, because what that means is we can never be absolutely certain going into an operation exactly what's going to happen at that operation. Uh-huh. And that's, I think, a really important point. And I think it's a very disconcerting thing for patients, because most of the time, if you're going in for a cancer operation, you know exactly what is going to happen. You have a a colon cancer, they're going to remove part of your colon, they're going to put it back together, or your breast cancer, they're going to either do a lumpectomy or a mastectomy. It becomes very clear what the procedure is. In these cases, there could be a wide range of things that are on that procedure list that we just don't know until we're there, until we see inside where the tumors are. And because some of these tumors can be very small as, let's say, 1 or 2 millimeters, again, our goal is to remove all the disease that we can see. So it can really extend what those procedures are going to entail. So when Jodi-Ann is talking to them about taking that bowel prep, for example, we don't know what part of the intestine we may need to remove. We just, and although there is some debate in the literature whether the intestine needs to be totally clear before we remove certain pieces, we certainly have found that certainly in our experience that it does have a positive environment if the bowel is clean, so to speak, as opposed to if there's a lot of stool in it. And especially for patients with ovarian cancer, because the bowel can be very negatively affected by these growths around it. So going back to really the point from the patient perspective, you're going into an operation and you may not know exactly what the outcome is going to be. Certain things can be almost certain, is that there'll be an incision that will be up and down in the abdomen that could go as far as the bottom of the rib cage in the midline to the bottom or the upper part of the pubic bone, the pelvic bone. And I think the other thing which you may talk about, and the doctor usually will talk about, which is the possibility of waking up with a bag, a temporary stoma. And we can talk a little bit more about that later in the podcast. But certainly, again, from the patient perspective, are they going to wake up? How big will the incision will be when they wake up? And will they or will they not have a bag?
Yeah.
Okay. So the staging then helps the team determine how extensive the cancer may be, although it may not provide all of the answers. And it also therefore helps the team, including the patient, decide on surgery up front or later on. And then at the time of the surgery, how extensive the surgery may be. Although I think you're trying to make the point that we don't really know until we're there what may need to be removed. For example, if the bowel is affected enough by the malignancy or the cancer, part of it may need to be removed, and the patient may have what we call colostomy, with a bag that will empty that part of the bowel of stool, at least temporarily. I think we might as well just talk about that point, trying not to make too much of it because there's so many other things to speak about. But can you tell us in people who present with advanced ovarian cancer, which would be the majority, how often this happens and how often that bag, the colostomy bag, is required, or for how long, I should say?
Sure. So I think two important points. So the first around the discussion, not knowing exactly what the inside of the abdomen will look like. We've come a long way with our CT scans, and the ability and resolution for us to be able to see what's happening have really improved, but nothing beats actually being there on the day of and seeing what the inside looks like. And so we always will prepare patients and have them know that it is possible that when we look inside, we change our mind, so to speak. We sort of say, you know what, today's not the right day for this operation.
Okay.
We should maybe treat you with chemotherapy first. So we're not going to proceed with taking anything out right now. We're going to look at this as a diagnostic procedure, meaning it's almost like doing an even better CT scan, really looking inside and saying, you know what, we don't feel we can get enough clearance today the way we want to. So we're going to start with the chemotherapy. And I think for patients, they need to know that that's not a situation that says, uh-oh, that means I'm in big trouble. You know what, they opened me and closed me up. That's it. Better start getting my affairs in order kind of thing. That's not what that means. That's really important, I think, for patients to understand that if they find themselves in that situation. It really just means that when they've had a closer look, that a chemotherapy approach is more appropriate for that individual.
Okay.
On the topic of the bag, so the first, I think, point of clarification is that we would very rarely do a colostomy. And obviously,
sorry.
a subtle difference, but essentially one is the bag because of the colon, or another term is something called an ileostomy, which is that the bag is from the small intestine, not the large intestine. We would typically do an ileostomy, which is the small intestine. And probably the reason for that is because it's a much easier thing to correct, so to speak, to put it back with an ileostomy than a colostomy, typically. And so that's I would say in the majority of cases in ovarian cancer surgery, if there's going to be a bag at the time of surgery, it would be an ileostomy, and definitely temporary, not permanent. We try to explain to patients that when we have a situation whereby the bowel has been put back together, and for whatever reason we think that they're at a higher risk than we are comfortable with, that there could be leaking from where the bowel was put back together, that would be the number one indication that we would put this temporary bag. It's an escape valve, if you will. I try to use the analogy of a piping system. You've cut the piping system, you've welded it back together. You just don't want the fluid going through that welded portion until it's completely secure. So you make an escape valve upstream from where it was put back together.
Great analogy. Yeah.
In terms of the timing of it, so typically speaking, because chemotherapy becomes an important part of the management of people with ovarian cancer, once we start the chemotherapy process, we typically don't want to interrupt it. And so the typical course for individuals is they'll have surgery. If they have the bag, it would probably stay there throughout the course of the chemotherapy, which is for the most part around 4 months.
Okay.
And then after that, a small procedure, a much smaller operation to then put that back. And then the person would essentially have completely intact bowels.
Okay.
The last point I'll make about it is a question that you asked, which is, well, how common is it? And that's variable. That could be quite variable depending on the institution where someone's being treated, how aggressive the surgeons are. We are trying to standardize our protocol. In fact, going back to some of the research initiatives that we're doing as part of this program, one of them is looking at this as a quality indicator to see how commonly people are choosing to use these bags, and can we reduce their use in some capacity. I would say it's about 15% right now. So the majority of the time, you do not need to do this as part of, patients will not need this as part of their treatment.
All right. Thank you. Thank you for explaining that.
I will also say, just from a patient education standpoint, because this can be life altering for the moment that it is in, that we do a lot of patient education, a lot of one-on-one with the patients in regards to if we have decided that an ileostomy is possible. Prior to the operation, they'll be seen by our stoma clinical nurse specialist as well. So go through what the ileostomy will be, what it will look like in regards to, as well as teaching how to manage it. That will be continued into their admission stay. And we'll also talk about products and how to get it and practical resources for after surgery.
Right. Okay. So all the bases are covered in the eventuality of this has to happen. All right. So we've gone through from the initial, well, before the initial visit to the initial visit, the supportive care and the preparation that's required up until the time of surgery. The morning of the surgery, I clearly remember the morning of the surgery. And you know, although I was pretty scared and my husband was pretty scared about what was going to happen, I have to say, while we were waiting in that pre-operative area, the holding area, I guess, or pre-op area, I couldn't have been greeted by a nicer, more professional group of people, from the nurse that was assigned to that area, to the nurses that were actually going to be involved in my surgery, to the anesthetists, the residents, and the physician, Dr. Bernardini. So, as bad of a situation as it was, I think that your team did everything possible to put my mind a bit more at ease. And so I remember it very well. Maybe you can, I don't know, you add on to that little phase to that morning of the surgery before it actually takes place. Anything else you want to add?
Going back to, again, the journey of the patient and so much going on. There's so many things happening in a very short period of time, from having had a lot of diagnostic investigations, including maybe getting fluid drawn or a biopsy prior to all of this, having symptoms that are not making them feel super comfortable. And so then it comes to the time of surgery, the morning of, again, after having gone through already a period of time with a lot of things going on, and there's a lot of anticipation. And as I mentioned earlier, one of the challenges, not even knowing exactly what the operation is going to entail, is something that we are aware of, and we try to make the patient feel as comfortable as possible. It's a busy area, as you may remember. It's a lot of activity going on. There's a lot of surgeries that are being done at the institution, lines, and people are putting in, intravenous lines, and people are coming to talk to you in the nursing team. And so, obviously there's a combination of efficiency in terms of having many things being done at the simultaneous time, but trying to always be very, very understanding, respectful for the patient, and understanding what they're going through. Yeah, one of the things that is a decision that generally a patient has to make would be the use of an epidural for pain management. Because, as mentioned, these incisions can actually be quite large. Pain control after surgery is an issue that we are always trying to deal with, because if someone has a lot of pain after surgery, it makes recovery more complicated in every way. So managing pain is usually the first step in terms of having a good post-recovery, post-surgery period. And so we have started to use more frequently epidurals for pain control. And that's something that a patient would likely be offered at the time of their surgery. And that would happen while they're still awake before the operation.
Okay. And then the patient is brought into the operating room. Can you just briefly describe the various tubes that are placed in the various orifices at that time?
Yeah, for sure. So the first thing that happens now, which didn't happen 10 years ago, but it's now standard practice in every operating room in the world, it should be in everywhere, is what they call a timeout. And that's a very, very important part of the surgery, because that's the part of the surgery where the patient is introduced firstly to everyone in the room, all the members of the team that are going to be part of the care while they're asleep. We'll be, again, reviewing the plan. What is the plan for surgery? Reviewing any concerns on the part of the anesthesia team, the nursing team, the surgical team. And so that's something that's done before the patient's ever been put to sleep.
Okay.
In terms of things, as mentioned, one would be the epidural. The epidural would be done before someone's put to sleep, if someone choosing to have that. There will be a breathing tube that is put in by the anesthesiologist, and that's done at the same time that someone's being put to sleep. That's really necessary because these operations can be quite long, and obviously the person needs to be paralyzed during the operation to facilitate the operation. So the breathing machine and the anesthesiologist is doing the breathing for the individual. And so sometimes patients after surgery, as you may or may not have recalled, that you can have a bit of soreness in the throat, and that's usually from that tube that's there. They'll put something called an arterial line, which is a direct measure of things like blood pressure and immediate response to heart rate. So that's an important measure for our anesthesia team. Patients will generally have certainly one intravenous, sometimes two intravenous. And if for whatever reason we think blood loss may be a little bit more, they would have a central line intravenous, usually that goes into the neck area at the time of their surgery. We will place a Foley catheter. That's a catheter that goes into the bladder, so that collects urine during the surgery, and that's pretty standard. And then depending on the operation and what ends up happening, patients may wake up with a tube that goes into their belly area that is collecting fluid, just to give us some information in the post-operative period. So that's not for all patients, but some patients wake up with that.
Okay. And then I had another tube that was placed into my stomach by way of my nose.
Yeah, thank you for
Lovely
reminding me. Yeah,
nasogastric tube.
correct. Yes, thank you for
Yes.
reminding. That is yet another tube that may be. It's not standard. It's not in all cases, but it really depends on the nature of the operation. So, for example, if there's a lot of surgery being done around the stomach area, if there was a lot of tumor in there, that yes, a person may wake up with a tube that is into their stomach. It does go through the nose, down into the stomach area to help collect some fluid, so it reduces edema, meaning swelling in that area, to help for healing. I must say that we don't do that routinely anymore, meaning patients don't routinely wake up with a nasogastric tube, but occasionally they will have that if we feel, and we would typically remove that within a day or two after the operation.
Okay, thank you for reviewing that. Jodi-Ann, how are the patients' families supported during the surgery? Sometimes they can be quite long and the families are very worried. So what's in place for them?
Sure. I usually, as well, during the initial education portion, is to let families or the patient know. And oftentimes I'm talking with the patient and their significant other, or whomever it is that they like to have on the phone with them at the time, to know how long the procedure might be or how long the wait will be, so they can set some expectation.
Mhm.
So there's been lots of changes with COVID, obviously, but there
Right.
is a family waiting area that's available for during the surgery that is open during regular times, that they can wait until the surgery is complete. During this period where we haven't had visitors and things like that, it's been a little bit more complicated. But once the surgery is complete and there's a moment, either the surgeon or their delegate will give the family member or loved, whomever it is, a significant person, a call to let them know how the surgery went. And then, so at least they'll have that peace of mind as well, to know that they will receive a call. I try to say exercise some patience, because it is, a busy day and some of these procedures are long. I mean, minimum 3 hours, could be longer depending on the extent of the surgery. So that's where the support does come in, whereas they are invited to come up to the surgical admission unit so they can start that process. They do have to leave at some point to go to the waiting area. If they're giving information about how long the surgery is, so that kind of reduces some of the anxiety, because they know that they'll have to wait a little while until they hear from the surgeon or the delegate how the surgery went. And so they have some idea of how things are before the patient is transferred up to the inpatient unit. I also give the family member the number for the inpatient unit sometimes. So I'm like, if you're worried about, are they upstairs yet? Can I visit? That they can give a call, and that the nurse is there or the admin who picks up the phone can say, okay, yes, the patient's here. No, they're not here yet, and kind of give them some support as to what's happening next, so they're not so out of it on the outskirts.
Okay, great. That's good. Now we're in the post-operative period. Dr. Bernardini's touched on the importance of pain management. He's gone over all the various tubes that may be present. You've talked about measuring important things like blood pressure and heart rate during surgery. I guess those things take place after surgery as well. I do remember that it was very important for the medical team that I try to get up out of bed and walk as much as possible. That was really emphasized. Dr. Bernardini, do you want to tell us why that's important?
Yeah, absolutely. There is a growing field, although it's been present already for quite some time, of a topic that's called ERAS, E-R-A-S, Enhanced Recovery After Surgery. I think this is an important element around the care for patients. And the fundamental principle is that you want to get people back to their normal physiological state as quickly as possible. And so someone who basically doesn't move out of their bed, that just kind of lies there, obviously physiologically, their body's not doing what we normally would do, because nobody is typically lying in their bed for 3, 4, 5, 6 days in a row. So things like getting the blood flow going, getting the muscles going, getting the intestine going, these are all factors that typically are associated with resume to normalish activities. And so getting up and moving around is a critical piece of that. I'll often joke with my patients that, I'll start to turn into a bit of a meanie on day number 3. And my usual line is to say, look, the bed is for sleeping. So if you're sleeping, no problem. If you're not sleeping, you shouldn't be in the bed. So either be in the chair, you can walk around, you can sit off the side of the bed, you can sit up if you want, but that's that principle. And really, as I mentioned earlier, it always goes back to pain management. So what a lot of times what people will say is, I don't want to take a lot of pain medication. I don't want to get addicted. I heard about this stuff. I don't want to do that. And, I think most importantly for people to realize that when you have acute pain, like a situation where you've had an operation, essentially had a big trauma, it's like being in a big car accident or that kind of thing,
Right.
You need pain medication. That's not a situation of getting addicted, or that's a situation of having to have appropriate management of something that has happened. And so what a lot of people will do is they'll say, I don't really want to take it, so I'm good. As long as I'm not moving, I'm feeling perfectly fine, so I'm not going to move. And we really discourage that. We want the opposite, in fact. We want someone to have the necessary pain control so that they can get up and move around.
I do remember that one of the problems that I had that made it difficult for me to be physically active was I was very swollen. I my legs were very swollen, my belly was swollen, and so movement was it was tough, but I did try to do what I could, even in the bed. I try to do the bicycle, lying on my back before I felt that I could get up and move, because I knew that even that activity would bring the fluid back up towards my heart, back into my circulation. But it was really tough to move. I remember one time I had a pain in my back, and you said, well, where's the pain? And I couldn't even point to the pain in my back. I kind of rolled over, and and you had to put your hand on my back. So it's tough. It's really tough. But I think with time and good pain management, as you're saying, that the all that extra fluid also decreases, and it makes it more possible for you to get out of bed, to get back to your, as you call it, your normal physiologic state. Yeah. Can you touch on, if there were, let's say, the 2 most common complications of this kind of surgery, what would you say they are? Or if you feel it needs to be more than 2 that you want to touch on, please feel free.
Yeah, I think when we talk about complications after surgery, we generally will break down the first 2 criteria. One would be infection, and the other one would be bleeding. So from an infection point of view, the most common complication that someone can have is some degree of an infection at some level with these operations. And that can range from the skin. So because again, these are big incisions on the skin, that they could have an infection at some level. A urinary tract infection, again, because we put a Foley catheter into the bladder to drain urine, that's introducing a foreign substance into the body, which always increases the risk of infection. And then infection related to the surgery itself is something that could be depending on what was done. So I mentioned earlier, if we put the bowel back together again, and if there's a small leak around that can cause an infection. Sometimes the spleen needs to be removed, and with that at the very tip of the pancreas, and sometimes there can be some leaking from that, and that can sometimes lead to a site of an infection. These are potential areas that are related to specifically to the operation the person may have had. And then the last thing is related to just in the recovery period. So, deep breathing and improving things around the lungs, because one of the things that can happen is you can get an infection in the lungs and pneumonia. It's something that can happen after surgery. So we are part of a quality indicator program called NSQIP, and we are always monitoring these types of complications and interventions to reduce them from happening moving forward. So that's the infection side of things.
Okay.
The bleeding side of things, I think some categorize a blood transfusion as a complication. We certainly warn patients that are going to have this operation that there's probably at least a 30% chance that a blood transfusion will be required either during the operation or in the post-operative period. Some of these operations can last as long as 10, 12 hours with a lot of organs being removed as part of the surgery. And again, it's just, I think, something that comes along with that kind of extensive operation.
Dr. Bernardini, can you try to simply tell our listeners why you should bleed if an organ is removed?
Sure. Yeah. I think, I think every organ in our body has what we'd call blood supply. So, you could sort of, let's take the ovaries, for example. So the ovaries have an area where blood comes in and blood comes out. And so if you control the area where blood comes in and blood comes out, then you can easily remove the organ and there should be very minimal bleeding. And in fact, most surgery today has minimal bleeding. The problem in these types of operations is, remember, we're starting with the point that all of the pickles in the pickle jar have a lot of tumors and growths on them. So it's not that everything is nicely where it's supposed to be. It's not that you have all that nice blood supply into an organ and out of an organ. And the anatomy, meaning what things should look like on the inside, is not what they look like because of the extent of the disease. And so in the process of removing all of that disease and trying to find those blood supply, the in and out, it's just a situation where as you're doing that, you end up having increasing blood loss. It is rare that you're in a situation where someone is bleeding out of control. We don't know where it's coming from. That's a very rare thing to happen. It's just more a function of you're doing this for 10 or 12 hours. There's a little bit of blood loss here, there, it adds up.
Right. Okay. Thank you.
Yeah.
All right. So you talked about infection and then bleeding. And if a person were to have some bleeding, the transfusion, meaning the replacement of the blood loss, could take place in the operating room or it could take place after the surgery is done.
And maybe just it's worth just adding, so there are a couple of other complications that we probably didn't touch on, and I think it's important for people to be aware of. One is the risk of blood clots. And especially with this diagnosis of ovarian cancer, we know there's a higher risk of blood clot formation. Those blood clots can not only originate in the legs, that's one of the reasons we do like people moving after surgery, but also in the pelvic veins, again, in relationship to these cancers and where they might be. And what the serious complication of all of this is that it could develop into a blood clot in the lungs, or what they call a pulmonary embolism. So we're very aggressive in reducing that risk in the hospital by giving prophylactic blood thinners. And as part of an initiative now, we actually send people home with those blood thinners for a period of 28 days after surgery. It's not the funnest thing for patients because they're injections that they have to give themselves. But certainly in doing so, we, in addition to other centers, have had a significant reduction in blood clots for these individuals after surgery. And the other thing is just, we talked about it a little bit earlier, just around bowel function, prolonged ileus, meaning the bowels are just stunned after this kind of operation, big, long operation, something that can keep people in hospital, sometimes 5-7 days until those bowels are going. And occasionally someone can have a bowel obstruction or a blockage of the bowel after surgery, although that one is certainly much less common. So
Good.
those are just two other complications that I think are worth.
Thank you for bringing them up. But another thing that comes to mind, I don't know that it would be categorized as a complication, but for women that have not yet had menopause, removal of the ovaries will put them into what we call surgical menopause. And that I think we should plan on making that the topic of another podcast as well. I know that at least when I went through this, we talked about this outcome of my surgery, and I talked about it some more with my family doctor, and I think it's worthy of another good half hour, 45-minute podcast.
And I just want to make a touch point on pain management, which during the patient education prior to surgery, we'll discuss that as well during my pre-op education with the patients in regards to proper and appropriate ways to manage pain, because it's not something that person thinks about on a day-to-day basis, right? Or even talking about early intervention or knowing when the best time to take pain medication and how it affects their sleep and their mobility, and that it always kind of comes back to pain management and how important mobility is for all of these processes to work perfectly, for them to get back to their diet, for that fluid that you were talking about, that buildup. Mobility will help to reduce it, and for you to be more mobile, we need to manage your pain. So it kind of all comes around. So doing that full circle education makes it make sense to say, okay, this is why I need to manage my pain, so that everything else will work in a smooth transition, so that we can have your length of stay be as done as appropriately as possible, that the experience is pleasant, and so that we can get you back to where you were before. Let's get you back to your baseline as you were before surgery. In regards to post-operative management, when you go home, pain management still continues to be important. So knowing how to use your non-narcotic medication, knowing how to maximize it, knowing to depend more on your non-narcotics, because people do have I don't want to take so much pain medication, I don't want to take a narcotic. So now it's okay to take it if you need it, but let's also depend on our non-narcotics first and how to use those to give you the most benefit, and then using your narcotic as your breakthrough for when the pain is a little bit greater, even though you've taken your non-narcotic pain medications. And that's a continuous process that I continue to support patients with even while they're at home.
And can you just explain what a narcotic is versus a non-narcotic, Jodi-Ann?
Sure. So we discharge patients home with the three usual suspects. So extra strength Tylenol, and then naproxen, which is an anti-inflammatory. We often sometimes use another type called celecoxib, and then also hydromorphone. So the hydromorphone is the narcotic, and then the non-narcotics would be the Tylenol and the naproxen. So when I say we want you to depend more so on the Tylenol and naproxen, the Tylenol and the naproxen you would take on a routine basis. So Tylenol is every 6 hours, naproxen is twice a day, once in the morning, once in the evening, 12 hours apart. It's a longer acting medication. And then, so with taking the Tylenol every 6 hours and the naproxen once in the morning, once in the evening, we're hoping together those will be enough to manage your pain. However, ever so often, you may need a little bit more. So when we get to that portion where you've taken your Tylenol, you've done the naproxen, and you still need a little bit extra because you're still having a lot of pain, then you take the hydromorphone. So that's the kind of conversation we have, so they understand how best pain management works.
So you're talking about the discharge period and the prescriptions that the patients will go home with. I guess the prescriptions, would they consistently consist of other medications as well, like a laxative, for example, to help them while they're on the pain meds, or any other drugs that you send patients home on?
We do send
in a standard way.
Send patients home with laxative, either Senna or Restore-Lax, to help with because the hydromorphone or the narcotic that of the choosing can cause constipation. So we ensure that they can take that once a day or once at night, or we increase depending on how well it's doing while they're at home. And so that they can have good bowel movements. I usually say the goal is to have a bowel movement every day or every other day. And if that's not being met, to notify so that we can work on interventions.
All right. I know I had problems with that aspect of things as well. And, I was able to reach out to Princess Margaret for guidance on how to get the bowels moving, because it can be very, very uncomfortable and even a sign of, other complications of this kind of surgery too. So that's important for patients to keep in mind.
Yeah, if I can just maybe add,
Sure.
so number one is I think Jodi-Ann has done a tremendous job, and the team. I think, as she mentioned, one of the things that we're really, really focusing on, and even more so now, is what we call prehabilitation. This idea of getting someone to their optimal state prior to surgery. There's a lot of research being done in this area right now. And so the idea of things like intravenous iron transfusion to optimize someone's state is something, it's just one of those examples. So Jodi-Ann, I think, has done a great job with that team. And then afterwards, of course, in the post-operative period, trying to work with individuals. The principles around narcotics and non-narcotics, I think, as you were describing, narcotics, for people to understand, are medications that can have addictive properties. That's probably the easiest way to kind of look at it. So a lot of the things, a lot of the drugs that we hear about that are really problematic in society today fall in that class of medications that are called opioids. And those opioids are the ones that are as Jodi-Ann was talking about, the hydromorphone, for example, which is also known as Dilaudid, is the one type of medication that we would often send people home with. It's extremely effective as a pain reliever, extremely, extremely effective, but it can have other types of side effects, and including potentially addictive properties. And so the whole principle of pain managers try to minimize the use of opioids as much as possible, as Jodi-Ann was describing. Of course, still needing it sometimes, because Tylenol, especially if we can't use naproxen in the cases, for example, of bowel resections, Tylenol often is not going to be enough. And to your point, and to what Jodi-Ann, as you rightly pointed out, taking some laxatives if you're taking the opioids, because those opioids are the ones that are really a problem in terms of constipation and that kind of thing. So, but Jodi-Ann and her team do a great job at really helping the individual tailor their post-operative pain requirements and what they're taking, and I think that's been a real great asset to the patients.
Great. Thank you for emphasizing the principles behind, the things that you do, including the medications that are prescribed. Of course, during the surgery, as you said, organs may be removed, or I guess they are removed, but the number of organs will depend from patient to patient. And samples of tissues are removed, and I guess those must be sent to the laboratory where they are studied. Do you want to tell us about what it is that is done, and then how the results of that are relayed to the patients, and how they're important in terms of determining next steps to after the surgery?
Yeah, no, absolutely. So obviously, everything that we remove from a patient at any time during any operation does get reviewed by the pathology team. So every organ that gets removed gets labeled and gets looked at to establish if there is any cancer associated with those organs, the integrity, anything that can establish, just from a staging perspective, going back to one of the earlier concepts of where was this cancer, where did it spread to, and what can we gain from the information in terms of the organs that were removed. Mm-hmm. At a secondary level, the tumor also gets tested, and the standard of care for today is that this tumor gets tested for two genes, the abnormalities in the BRCA1 and BRCA2 gene. And that's important because many people may have heard about these genes and also heard about genetic predisposition, meaning that in their bloodstream, that some individuals have an abnormality in one of those two genes, BRCA1 or BRCA2. But it's important to note that some cancers can have the abnormality in the BRCA1 or BRCA2 gene, even if the individual does not have a genetic predisposition, meaning there is no abnormality in their normal bloodstream, in the blood cells that make up, or all cells that make up their body. But the tumor could develop those abnormalities. And so that's why it's very important for us to test the tumor, not just test the bloodstream for the individual. And that's important because there are new medications which are available for the management of ovarian cancer patients today that are dependent on whether they have a mutation in the BRCA1 and BRCA2 gene. We're currently involved in a study trying to look at expanding the genes that are assessed within the tumor. So not just BRCA1 or BRCA2, but the full panel of genes that we typically assess in the bloodstream, which is standard of care today. And we're trying to see if that can, in some ways, improve the process around testing for patients and improve the workflow for them. And that's something that's going on. But I do think as we move forward into the future, many genes are going to be assessed on the tumor at the time of an operation because it's very valuable information for the care of patients.
Yeah, again, so it's valuable because of it may impact the treatments that the patients that are open available to the patient after the time of surgery and the initial chemotherapy, I guess.
Correct. That's exactly.
Great. And how long does it take for at least the initial results of the laboratory pathology testing to come back?
Yeah, so I mean, as you can imagine, often there's a lot of specimens that are given to the pathologist. So it does take time for them to accurately evaluate all the tissue from surgery. One of the other important elements around surgery and going back to the recovery piece, we want people to get back as healthy as possible, as quickly as possible, because we need to start chemotherapy in the vast majority of patients. And the sooner at some level that we start the chemotherapy, the better it is. And so the standard is probably about 3 or 4 weeks after the surgery that they're ready to get on with chemotherapy. And we need the pathology information back beforehand. So almost as a systematic workflow issue, typically it takes about 2 or 3 weeks for the pathology to be reviewed. And typically that will coincide with the first post-operative visit in the clinic of the doctor, where they will then discuss that pathology and organize the chemotherapy moving forward.
Okay, good. I think we've done a pretty good job of providing timelines, within their ranges, of course, but it's good for, I think, our listeners to know what to anticipate in terms of timelines throughout this whole initial part of the journey.
Yeah, I think it is important also to comment, because listeners to this podcast may not just be from the Ontario area in Canada, maybe elsewhere, that the answer to that question is probably dependent on where the individual may be. So in some areas, the pathology reports may come out significantly faster than the 2 to 3 week period. And some institutions are able to get people into chemotherapy maybe even a little sooner than 3 to 4 weeks. So people have experimented, including our center at some point. We're experimenting even as early as 2 weeks after surgery. It's a multifactorial process. Again, depends on the operation that someone's had and the recovery time. But one of our quality indicators that we are working on is trying to find what is that optimal time that we should start chemotherapy after these operations.
That's great. Maybe we should have a podcast on the quality indicators that the program has. I think that's super interesting what you're doing, and it's a reflection of the 3 pillars of your program, I guess, the quality indicator program, and I find that really, really interesting and very inspiring.
Yeah, I think that's a great idea, and I think that it is something that we are always trying to aspire to just better and better and better. There's always a better way to do things. And so by defining what those metrics that are critically important for individuals are, and then establishing what are the quality indicators that can help us to define the best treatment for people, that's what we're always working towards. So I think that's a great idea. And we do have a number of initiatives that we're currently undertaking.
Excellent. Good. Jodi-Ann, is there anything else you'd like to discuss with regards to the discharge piece? We talked about prescriptions. Dr. Bernardini talked about that first post-operative appointment. Presumably the support systems are in place there. Well, you talked about being there for the patient should the patient need you for questions.
In regards to support, they'll have access to myself. They usually have my number to call. Should there be any new or concerning symptoms while at home, we'll triage them at the time and start interventions. Sometimes it's something we can manage at home. Sometimes we have to come back to clinic, and sometimes, unfortunately, it has to come back through to the emerge. I'm the liaison between the patient and the clinic and their surgeon. So it will, depending on what symptoms they're experiencing, the pathway will differ. And then so that relationship between myself and the patient carries on through their recovery period, approximately 6 weeks, approximately 4 to 6, depending. And so that's how the support is done after surgery. They'll go home with the prescription. They'll go home with a discharge summary, which is very important as well. That talks about the entirety of the operation and their stay, and what to follow up with. So oftentimes we will have the date of the follow-up, sometimes not, it just depends. So the date of their follow-up, which is usually, like Dr. Bernardini said, in about 3 to 4 weeks, instructions on what to do after surgery. We'll talk about staple removal because the midline incision is closed with staples, and those staples are removed post-op day 14, so 2 weeks after surgery. So there's that reminder there as well, to follow up with your family doctor to remove those staples, and we'll discuss that during that period in time.
All right. Well, I'm sure our listeners are in agreement that we have talked about many, many facets of surgery for a person who is diagnosed with ovarian cancer. And in my opinion, there's no way about it. It is, as Dr. Bernardini said, it's a complex disease, and the management it's not very straightforward or simple. It needs to be individualized. And there are many different facets to it. And so along with that comes lots of knowledge to be gained. I want our listeners to know that although this might sound overwhelming, as both Dr. Bernardini and Jodi-Ann have very clearly made apparent, the support is there. The support is there. So for anyone that has questions or needs to discuss any one of the many issues we've talked about, I know that this program will be there to support you and help you feel as comfortable as you can be during this difficult time. And so I'd like to thank the two of you. I think Dr. Bernardini, as division head of the Gynecologic Oncology program at Princess Margaret, you've really provided us with some very valuable information. And Jodi-Ann, clinical nurse specialist with the program at Princess Margaret, it's been a pleasure meeting you and learning more about what it is that you do. And it's quite obvious what your value is to the program. So thank you both.
Thank you.
Yeah. Absolutely. Thank you. Our pleasure. And, just maybe one last message for the listeners. If for some reason you're listening to this because you have a new diagnosis or a suspicion of a diagnosis of ovarian cancer and going to have surgery, most importantly, just make sure that the center where you're having that operation is a high volume center, that they really manage a lot of patients like this. These are very important operations in the overall healthcare scheme. And ask questions, because us as a team and any doctor and any team are there to answer your questions, and don't ever be scared to ask questions.
Great. Thank you, everyone.